بسم الله الرحمن الرحيم. I would like to thank the audience for giving me their valuable time to present this lecture. I hope it will be beneficial for everyone. Our topic today will be about management of bleeding disorders in adolescents with heavy menstrual bleeding. So, what is the definition of adolescence? According to World Health Organization, adolescence transitional phase of growth and development between childhood and adulthood. WHO, the World Health Organization, defines an adolescent as any person between age 10 and 19. Short notes about normal physiology. The normal menstrual cycle depends on the feedback loops of estrogen and progesterone, on the production of luteinizing hormone and follicle-stimulating hormone by the pituitary gland, and on the hypothalamus normal function as metronome for the hypothalamic pituitary ovarian axis. The hypothalamic pituitary axis. The hypothalamus secretes hormones or factors which control the activity of pituitary gland. We have gonadotropin releasing hormone and prolactin inhibiting hormone, which is dopamine. The gonadotropin releasing hormone stimulate the pituitary gland to produce follicle stimulating hormone FSH and luteinizing hormone LH from the basophil cells of the anterior pituitary gland. Because it is secrete more LH than FSH, the gonadotropin releasing hormone is often called luteinizing hormone releasing hormone LHRH. The gonadotropin releasing hormone is secreted in pulsatile manner every 60 to 90 minutes in the follicular phase and every 120 to 180 minutes in the luteal phase and reach the anterior pituitary via the hypophyseal portal vessels. So, the anterior pituitary gland secrete FSH, LH hormone under the effect of pulsatile release of gonadotropin releasing hormone. The ovarian cycle. In the first half of menstrual cycle, the anterior pituitary secrete both FSH and LH. The follicle stimulating hormone, or FSH, stimulates the growth of several primary follicles in both ovaries. However, only one follicle reach a maturity and form a Graafian follicle which secrete increasing amount of estrogen or estradiol. The estrogen level reach a peak about 48 hours before ovulation, day 12. This estrogen peak stimulates increased secretion of LH, which reach a peak about 36 hours before ovulation. The LH peak lead to ovulation and corpus luteum formation. The LH maintains the growth of the corpus luteum and stimulate it to secrete estrogen and progesterone. When progesterone reaches a high level, it inhibits the secretion of LH. This is followed by degeneration of corpus luteum. This leads to a drop in the level of estrogen and progesterone, causing separation of the endometrium and menstruation. Also, the drop in the level of these hormones stimulates the hypothalamus to secrete more GnRH, and thus a new cycle is started in. The lifespan of corpus luteum is 14 days plus or minus 2 days. And as we see in this slide, the negative and the positive feedback loops, how they can affect the normal menstrual cycle. Now we need to know some data about menarche. Menarche is the first menstrual period. Usually occurs between 12 years and 13 years. Typically occurs within 2 to 3 years after telarche. At Tanner stage 4 breast development, and is rare before Tanner stage 3 development. By the age of 15 years, 98% of females will have had menarche. It is important to know what is the normal menstrual cycles in adolescent girls. Median age for menarche 12 years, 0.4. Mean cycle interval 32.2 days in first gynecological year. Menstrual cycle interval typically 21 to 45 days. Menstrual flow length 7 days or less. Menstrual product use 3 to 6 pads or tampons per day. It is important to remember that menstrual cycle interval in adolescent typically 21 up to 45 days. It is different than menstrual cycle interval in adulthood. So we need to know what is the menstrual abnormalities that may require evaluation. Menstrual periods that have one or more of the following criteria: have not started within 3 years of telarche, have not started by the age of 14 years old of age with signs of hirsutism, have not started by the age of 14 years old of age with a history or examination suggestive of excessive exercise or eating disorder, have not started by the age of 15 years old. Also, menstrual periods that considered to be abnormal and need evaluation, if occur more frequently than every 21 days or less frequently than every 45 days, occur 90 days apart even for one cycle, last more than 7 days, require frequent pad or tampon changes, soaking more than one every 1 to 2 hours, and menstrual periods which are heavy and are associated with a history of excessive bruising or bleeding or family history of bleeding disorder. All of the above and the previously mentioned menstrual criteria considered abnormal and may require evaluation. Definitions. What is the definition of abnormal uterine bleeding? AUB. Abnormal uterine bleeding is a term recently favored over the previously used dysfunctional uterine bleeding, DUB. And the American College of Gynecologists refers to menstrual flow outside of normal volume, duration, regularity, or frequency. What is the definition of heavy menstrual bleeding? Heavy menstrual bleeding has previously been defined as a quantification of hemoglobin or an estimation of menstrual blood loss by volume more than 80 milliliter. Recently, the clinical definition is excessive menstrual blood loss which interfere with the woman's physical, emotional, social, and material quality of life, and which can occur alone or in combination with other symptoms. This definition adopted by FIGO and by UK NICE guideline. In 2011, the Federation of International Gynecology and Obstetrics, FIGO, proposed a new classification system for causes of abnormal uterine bleeding called PAL-COEIN system. I will discuss this one after a while. In the same time, FIGO also issued a recommendation on the nomenclature used to describe menstrual function, in which confusing previously used terms such as menorrhagia, metrorrhagia, polymenorrhea are discarded in favor of the term used in the slides in front of your kind care. So, according to FIGO systems, there are clinical variables, descriptive term for these clinical variables, and normal value for these clinical variables. The clinical variables are frequency of menses, regularity of menses, duration, volume either objective and volume subjective. And for each one of these clinical variables, there is descriptive term and normal reference for that. It is very important to mention that. First, this FIGO system applied for women in reproductive years, while parameters for the perimenarchal years are not specified. Second thing, there is update for 2011 FIGO classification system was done in 2018. The third thing I would like to mention, this FIGO system of nomenclatures and the causes of abnormal uterine bleeding now get more popular and recognized by many respectable OBS and gyne organization, looks like American College of Gynecologists. So it get more popularity and replaced the old definitions we are accustomed to use. As I mentioned, FIGO proposed a new classification system for causes of abnormal uterine bleeding in reproductive age. It is called PAL-COEIN. This classification was published 2011 and revised 2018. PAL-COEIN, it is a stand for polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. This classification was endorsed by American College of Gynecology in 2012 and revised, as I mentioned, in 2018. I kindly refer you to the two-figure system in the reproductive years, published 2011 and revised in 2018. The two papers are available online for free download for your kind attention and your kind review. Now, test your knowledge. MCQ. What is the second most common cause of abnormal uterine bleeding in adolescents? What is the second most common cause of abnormal uterine bleeding in adolescents? Is it anovulatory dysfunctional uterine bleeding, structural abnormality, or primary bleeding disorders? If you select anovulatory dysfunctional uterine bleeding, your answer is not correct, because anovulatory dysfunctional uterine bleeding is the most common cause of abnormal uterine bleeding in adolescents due to immaturity of hypothalamic pituitary ovarian axis. If you select structural abnormality as a second most common cause of abnormal uterine bleeding in adolescents, your answer is not correct. Why? Because structural abnormality represents only 7% or less of causes of abnormal uterine bleeding in adolescents. But the most second common cause of abnormal uterine bleeding in adolescents is the subject of our topic today. It is the primary bleeding disorders. So the primary bleeding disorder considered the second most common cause after anovulatory causes. So it is very important to pay attention to how you can pick up, how you can screen adolescents with abnormal uterine bleeding to diagnose primary bleeding disorder as under cause of hair problem. And this is the heart, the target of our topic today. As we see, abnormal uterine bleeding in adolescents can be caused by anovulatory disorder in 74%, bleeding disorders in 19%, and structural and other causes in 7% or less. So bleeding disorders are very common in comparison to structural abnormalities. Common bleeding disorders in adolescents who present with heavy menstrual bleeding include von Willebrand disease, type 1, type 2, and type 3, platelet functional defect as Glanzmann thromboathenia and Bernard-Soulier syndrome, thrombocytopenia, either primary or secondary, clotting factor deficiency, fibrinolytic pathway defect. Von Willebrand disease. Von Willebrand disease is a genetic disorder caused by missing or defective von Willebrand factor. Von Willebrand disease is the most common inherited bleeding disorder affecting about 1% of all population. It is carried on chromosome 12 and occurs equally in men and women. Von Willebrand disease is classified into 3 types: type 1, type 2, and type 3. Type 1 is the most common form, account for 3/4 of the cases, but it is the mildest clinically form. The defect usually in the number or amount of von Willebrand factor, so quantitative defect, but the function is normal, inherited as autosomal dominant. Type 2, there are many subtypes under type 2, looks at subtype 2A, 2B, 2M, 2N. Here the defect is qualitative defect in the quality itself. So it is dysfunctional defect in the von Willebrand factor. The number is normal, but the function is abnormal, inherited as autosomal dominant, and this is the most common form of inheritance in type 2, but can be autosomal recessive, and it is uncommon form of inheritance for von Willebrand disease type 2, and the clinical manifestation ranging between moderate to severe bleeding. Type 3 account for less than 5% of cases, characterized by profound quantitative defect, total or near total absence of von Willebrand factors, inherited as autosomal recessive, and clinically it shows severe bleeding, clinically similar to hemophilia A. Platelet functional defects. Thromboathenia. Thromboathenia means the defect in the function of the platelet, while the number or the amount of the platelet was normal. Example of thromboathenia: Glanzmann thromboathenia, Bernard-Soulier syndrome, delta storage pool disorders. Glanzmann thromboathenia, it is the defect of platelet aggregation. In Glanzmann thromboathenia, abnormalities of the platelet membrane glycoprotein 2B or 3A that mediate binding to fibrinogen, resulting in reduced platelet aggregation. In Bernard-Soulier syndrome, it is inherited deficiency in platelet membrane glycoprotein complex 1p9 causing defective adhesion of the platelet to subendothelial matrix. So, in Glanzmann thromboathenia, the problem in the platelet aggregation, while in Bernard-Soulier syndrome, the defect in the platelet adhesion. What about delta storage pool disorders? It is disorder of platelet secretion due to defective in platelet activation factors. So, in delta storage pool disorders, the defect in platelet activation. At the end of the lectures, you will see 3 diagrams showing the platelet aggregation, platelet adhesion, and the platelet activation defects. Thrombocytopenia, low platelet count, can be associated with idiopathic thrombocytopenia or immune-mediated thrombocytopenic purpura. Clotting factor deficiencies. Deficiencies of any major clotting factor, factor 8 deficiency, hemophilia A, factor 9 deficiency, hemophilia B, are symptomatic carriers due to X-linked inheritance. but can occur due to inactivation of the X chromosome carrying the normal gene. Framework up for adolescent with heavy menstrual bleeding. It will include history taking, physical examination, investigations, management of acute bleeding, maintenance treatment, and short important clinical notes. History taking. Evaluation of adolescent with abnormal uterine bleeding depend mainly in history taking, especially menstrual history, history of menarche, history of quality of life, bleeding history, medical history, and family history. When obtaining a medical history, it is important to identify risk factors for bleeding disorders, as well as medical conditions that would alter management. As a physician, when we evaluate adolescent with abnormal uterine bleeding, we must put in our mind two things. The first thing, to evaluate if this adolescent actually have abnormal uterine bleeding or no, and if yes, the most important questions is there is any underlying primary bleeding disorder which causes this abnormal uterine bleeding or no. So our target to discover, exclude, or confirm underlying bleeding disorder. There is a screening tool to identify adolescent with heavy menstrual bleeding for testing and evaluation for underlying bleeding disorder. This tool called Philip tool. It is one of the tools which can be used. This Philip tool includes many questionnaires. For example, how many days did your period usually last from the time bleeding began until it completely stopped? How often did you experience a sensation of flooding or gushing during your period? During your period, did you ever have bleeding where you would bleed through a tampon or napkin in 2 hours or less? Have you ever been treated for anemia? Has anyone in your family ever been diagnosed with bleeding disorder? Have you ever had a tooth extracted or had dental surgery? Did you have a problem with bleeding after tooth extraction or dental surgery? Have you ever had surgery other than dental surgery? Did you have bleeding problem after surgery? Have you ever been pregnant? Have you ever had bleeding problem following delivery or after miscarriage? The screening tool is considered to be positive if one of the following 4 criteria were met. Number 1, the duration of menses was greater than or equal to 7 days, and the woman reported either flooding or bleeding through a tampon or napkin in 2 hours or less with most periods. Number 2, a history of treatment of anemia. Number 3, a family history of a diagnosed bleeding disorder. Number 4, a history of excessive bleeding with tooth extraction, delivery or miscarriage or surgery. So, if the screening tool is positive, the adolescent girl must be subjected for testing and evaluation for underlying bleeding disorder. To help standardize menstrual blood loss, the pictorial blood assessment chart score was created. Each woman fills in the chart how many pads or tampons she uses each day, and to which degree they are soiled with blood according to the three alternative pictures on the diagram. A score is calculated by multiplying the number of pads and tampons by factor of 1 for lightly soiled items, 5 for medium soiled items, and 10 for totally soaked tampons, and 20 for totally soaked pads. And according to the final score, the degree of menstrual loss can be evaluated in accurate manner. Clinicians are encouraged to use the different tools to guide them in assessing for abnormal menstrual flow in their adolescent patients. Numerous mobile device period tracker apps have been developed, which are extremely helpful for recall of bleeding days during follow-up visits. Quality of life measures should be considered in clinics treating adolescents with heavy menstrual bleeding. Adolescents with heavy menstrual bleeding miss more days of school with each menses and have decreased sports participations and increased disruption of their hobbies and leisure activities owing to menses compared with their typically menstruating counterparts. In addition to, they may suffering from more times of stress or even depression in comparisons to their counterparts. Family history is very important item during history taking. Family history may be the clue to discover the underlying bleeding disorder in adolescents with heavy menstrual bleeding. Also, it is very important when we deciding the mode of treatment by evaluating the underlying risk of deep vein thrombosis when we decide to give type of hormonal treatment. So, family history of bleeding, clue for inherited bleeding or autoimmune disorder. Family history of arterial or venous thrombosis gives the risk of deep vein thrombosis in patients on systemic hormonal therapy. When determining whether a patient has a bleeding disorder, certain aspects of patient examination should be focused on. Thorough examination of the patient is very important. Adolescent girl must be examined for signs of hyperandrogenism, looks like hair loss, hirsutism, acne. Maybe the underlying cause of her menstrual problem is polycystic ovary disease or polycystic ovary syndrome. Also, thorough examination of the skin for manifestation of anemia, looks like pallor, or for bruising, hematoma, and petechiae, and inspection the nares and oral cavity for signs of allergic rhinitis, bleeding, or wet purpura. Also, the patient should be examined for signs of thyroid disease, such as hair loss, dry skin, for hypothyroidism, or excessive sweating and tachycardia for patients with hyperthyroidism. If a patient has a vaginal bleeding, you must make sure this is appropriate with sexual maturity level, means sexual maturity rating, Tanner staging 3 and above, and not due to other sources, looks like trauma. Abdominal examination for hepatosplenomegaly, maybe it is underlying cause for her abnormal bleeding. Also, the hemodynamic stability must be evaluated, including orthostatic blood pressure and pulse. Speculum examination typically not required under typical condition, but if it is indicated in sexually active girl and you are concerned about sexually transmitted infection, it can be justified. In sexually active patient, gynecological examination can be considered if we suspect genitourinary infection, as we mentioned. During examination also, we need to focus on the joint evaluation for bleeding, because in some primary bleeding disorder, it can be so severe to the degree it causes bleeding inside the joint, and we must evaluate the hypermobility of this joint, and it is one of the clinical signs can be used for diagnosis or screening underlying bleeding disorder in adolescent with heavy menstrual bleeding. Finally, don't forget consent, even oral consent, before starting any examination. Confidentiality for the patient must be kept priority, and chaperone is essential even if female doctor examine adolescent. Imaging recommendation. I will refer you to the committee opinion published December 2015 and revised 2020 by the American College of Obstetrician and Gynecologists. They stated that structural causes of acute abnormal uterine bleeding in adolescents are rare. Thus, the use of imaging in this age group may not be helpful in diagnosis. Routine ultrasonography shouldn't be obtained solely for the workup of heavy menstrual bleeding in adolescents. However, it can be considered for patients who don't respond to initial management. The decision to perform an imaging examination should be based on the clinical judgment of the obstetrician, gynecologist, or other gynecological care provider, and if deemed necessary, transabdominal ultrasonography may be more appropriate than transvaginal ultrasonography in adolescent patients. Investigations. Evaluation of adolescent girl who present with heavy menstrual bleeding should include assessment for anemia from the blood loss, the presence of an endocrinal disorder leading to an ovulation, and evaluation for the presence of bleeding disorder. So the investigations will include beta HCG to ruling out pregnancy, full blood count to see hemoglobin and hematocrit level, serum ferritin to see the iron store, taking in consideration that sometimes serum ferritin can come normal secondary to inflammatory process while the patient is anemic. Ruling out endocrinal disorder looks like thyroid disorder if clinically suspicion looks like excessive sweating, hair loss, dry skin, so we'll do thyroid stimulating hormone free T4. Test to exclude sexually transmitted infections, and if we suspect polycystic ovarian disease, we will do testosterone free androgen index, DHEAS, and prolactin level. Investigations to diagnose or rule out underlying bleeding disorder. Von Willebrand disease, it will be diagnosed through activated partial thromboplastin time, APTT, von Willebrand antigen, von Willebrand activity, von Willebrand factor resistin cofactors, factor 8 level. Thromboathenia, Glanzmann thromboathenia, we will request platelets aggregation studies because it is a defect of reduced platelet aggregations. Clotting factor deficiencies, isolated increased prothrombin time, PT, usually it is factor 7 deficiency. Isolated increase activated partial thromboplastin time, usually factor 8, 9, and 12 deficiency. Combined increase prothrombin time, PT, or activated partial thromboplastin time, they indicate factor 2, 5, and 10, and fibrinogen level deficiencies. Investigations if we suspect or need to diagnose thrombocytopenia, platelet count. If we need to diagnose fibrinogen pathway defect, we will request fibrinogen level or thrombin time. Management of bleeding disorders in adolescents with heavy menstrual bleeding. The map of management, it will include acute management for acute attack of heavy bleeding and the long-term management after control of the acute attack of heavy menstrual bleeding. The acute management will be divided into medical management and non-medical management. The medical management for acute heavy bleeding will be either hormonal medical therapy or non-hormonal therapy, and the role of transfusion. Non-medical management for acute heavy bleeding either will be intrauterine balloon or uterine evacuation, surgical. Regarding the long-term management after we control the acute heavy bleeding, what is the long-term management? I will discuss systemic hormonal management as long-term treatment, intrauterine devices, and non-hormonal treatment for anemia. Now I will discuss the acute management of heavy menstrual bleeding. Acute management for adolescent with heavy menstrual bleeding coming to your hospital with heavy menstrual bleeding. So the algorithm for start with initial assessment for vital signs, including orthostatic blood pressure, heart rate, proper history taking, appropriate physical examination. Before starting blood transfusion, if indicated, or any medication, order the following investigations according to your clinical judgment: urine to rule out pregnancy, full blood count and ferritin to see the degree of anemia. If you suspect a thyroid disorder, order for thyroid functional test. If you suspect polycystic ovarian disease as underlying cause, you will request testosterone-free androgen index, prolactin levels, DHEAS. If you suspect it is sexually transmitted infections, you will request for gonorrhea and chlamydia investigations. If you suspect it is underlying bleeding disorder, you will request prothrombin time, activated partial thromboplastin time, INR, fibrinogen level, von Willebrand activity, von Willebrand antigen, factor VIII activity, and you will request to group and hold. The type of investigations will depend on your clinical judgment, guided by the patient history and the result of examinations. After that, you will evaluate severity of bleeding. It is severe bleeding or non-severe bleeding. How you can evaluate severity of bleeding? You will evaluate and ask yourself, it is active diffuse heavy bleeding, or the patient use more than one pad every hour or every 2 hours, or vital signs of the patient indicate hypovolemia or orthostatic hypotension, or the blood came back hemoglobin less than 8 or hematocrit less than 25. According to the answers, you can evaluate it is severe bleeding or non-severe bleeding. So, if the result and the answers for your questions is no, so if the bleeding severity was evaluated as non-severe, so this patient is suitable for outpatient management. We will consider to give her antiemetic, because if we give her estrogen, it can cause nausea and vomiting, so the medicine can be less effective. We will start to oral combined contraceptive pills if no contraindication, or if there is contraindication to estrogen, we can give the patient progesterone taper. Taper means a specific dose to be gradually decreased. I will discuss this after a while. In outpatient management, schedule follow-up appointment within 7 days. So we'll give the patient appointment within 7 days for evaluation. Return if no improvement within 24 hours. So it is not absolute outpatient management. No, we will ask the patient and follow up here within the next 24 hours. If no improvement, she will come to be admitted as inpatient, and this is very important. Also, we will start oral iron, and we will consider stool softener because oral iron can cause constipation. If the patient, while she is outpatient and no improvement in spite of the medication, we will ask her to come for admission as I mentioned before. But if there is improvement, we will keep her in maintenance therapy in the form of continuous active pill only until hemoglobin is normalized. Continuous and active pill only until hemoglobin is normalized. Re-evaluate hormonal option for management of heavy bleeding. Oral iron until iron stores are sorted by normal ferritin, and stool softener if indicated. Again, if this patient not improved after you evaluate her severity of bleeding when she came for you for the first time, and you asked her to be outpatient and evaluate her in 24 hours and no improvement, or if you evaluate severity of bleeding and the bleeding was severe, what is the management? The management will be inpatient admission. So we admit the patient which come for heavy menstrual bleeding and all criteria indicate severe bleeding. Also, we admit the patient which has no severe bleeding but not improved after 24 hours of evaluation as outpatient. So what we will do as inpatient? We will consult hematologist, multidisciplinary team. It is very important. We will consider pelvic ultrasonography. Here the imaging quality is, the imaging investigation is necessary and must be considered. We will consider blood transfusion if hemodynamically unstable. We'll see if there is contraindication for estrogen or no. And according to if there is contraindication to estrogen or no, will decide the further management. So while the patient inpatient, we will ask ourselves, is there any contraindication to use estrogen for this patient? And if the answer is no, we will start estrogen therapy for her. The estrogen therapy, if the patient can tolerate oral treatment, we will start with combined oral contraceptive taper. Taper means specific dose. I will discuss here later on. If the patient can't tolerate estrogen therapy per oral, we can give Premarin 25 mg IV every 4 hours. When bleeding slows or stops, then start combined oral contraceptive tapers and begin antiemetic. Start the antiemetic. If there is contraindication for estrogen, so what is the alternative? The alternative will be progesterone therapy, per oral medroxyprogesterone high dose 60 to 80 milligram BID, means twice per day, until bleeding stops, then start progesterone taper. And will follow the bleeding. If the bleeding stops, it is good news. We'll review discharge criteria. Stable bleeding. Hemoglobin is stable. Patient can tolerate oral therapy. Patient must be scheduled for follow-up therapy within 7 days. And when she came after 7 days, we can keep maintenance therapy. What is maintenance therapy? Continuous active pills only until hemoglobin is normalized. Re-evaluate hormonal options for management of heavy bleeding. Oral iron until iron store restored by normal ferritin. Oral iron until iron stores restored by normal ferritin. Stool softeners, PRN, or when indicated. But if the bleeding after estrogen or progesterone therapy while the patient in the hospital continue, what we will do? Consult hematologist. Again, add antifibrinolytic and consider balloon tamponade to stop the bleeding. It is acute heavy bleeding while the patient not responding to your hormonal treatment. Regarding combined oral contraceptive taper regimens, we will use monophasic 30 to 50 microgram senile estradiol with norgestrel or levonorgestrel. Start monophasic 30 to 50 microgram senile estradiol containing combined oral contraceptive pills every 6 to 8 hours and taper as tolerated to maintain control of bleeding. Skip placebo pills and start next packet active pills. What about progesterone? Progesterone only taper regimen. We can use medroxyprogesterone 10 mg every 4 to 6 hours or norethindrone 20 mg every 8 hours, tapering as tolerated to maintain control of bleeding. Remember, combined oral contraceptive taper and progesterone only taper used in acute management of heavy menstrual bleeding in adolescent with bleeding disorder. After control the acute situation, we can move to maintenance therapy. Now, test your knowledge. Select which is not contraindication to estrogen therapy. Select which is not contraindication to estrogen therapy. Migraine with aura, hypertension, prior deep vein thrombosis and pulmonary embolism. Second group, transplantation, congenital heart disease, increased risk of clots. Third group, none of above. So, which group considered non-contraindication? Group 1, migraine with aura, hypertension, prior embolism. Group 2, transplant, congenital heart disease, increased risk of blood clots. Group 3, none of the above. The best and the right answer, none of the above, because the other groups are contraindication to estrogen. Here I will show you the estrogen and the progesterone taper used in management of acute heavy menstrual bleeding. Remember, this for acute heavy menstrual bleeding, not for maintenance therapy. Remember this. Regarding IV estrogen, it will be conjugated equine estrogen. Suggested dose 25 milligram IV. Frequency, it will be every 4 to 6 hours for 24 hours. Combined oral contraceptive per oral. The suggested dose in acute heavy menstrual bleeding, it will be monophasic combined oral tablet that contain 30 to 50 microgram of sentinel estradiol. So we'll use monophasic combined oral contraceptive pills that contain 30 to 50 microgram of sentinel estradiol. What is the dose? Every 6 to 8 hours until cessation of bleeding. So we'll give one tablet every 6 to 8 hours until cessation of bleeding. This is called estrogen taper. Regarding progesterone, orally medroxyprogesterone acetate 20 milligrams oral. Will give this 20 milligram oral 3 times per day for 7 days. So it will be 3 times per day for 7 days, and every time we will give 20 milligram oral. Regarding use of antifibrinolytic, I will mention here the dose of tranexamic acid in adolescents. It will be 1.3 gram oral, 1.3 gram oral, or 10 milligram per kg IV, and the maximum dose will be 600 milligram per dose. Again, tranexamic acid, remember, 1.3 gram oral or 10 milligram per kg body weight of the patient IV. And what is the maximum dose for per dose? It will be 600 milligram per dose. How we can give this tranexamic? 3 times per day for 5 days every 8 hours. So we can give 3 times per day for 5 days every 8 hours. And the dose, as we mentioned, 0.3 gram oral or 10 milligram per kg IV. The maximum per dose is 600 milligram. We will discuss the non-hormonal management of acute heavy bleeding in adolescent with bleeding disorder. So it is acute management in adolescent which already have underlying bleeding disorder. We discussed the hormonal treatment. What about the non-hormonal treatment? Antifibrinolytic, tranexamic acid, oral and intravenous, may be used to stop bleeding. No increased risk of venous thromboembolism when it is used with estrogen, although studies are very limited. The American College of Obstetrician and Gynecologists considered it a reasonable approach to management when other options have failed. Non-medical management in case of acute heavy menstrual bleeding in adolescent with underlying bleeding disorder. Procedural interventions in adolescent usually are considered second-line treatment given the presumed desire for future fertility. Non-medical procedures should be considered when there is lack of response to medical therapy, if the patient is clinically unstable despite initial measures, or when severe heavy bleeding need further investigations such as examination under anesthesia. In case when a thickened endometrium is suggestive of clot or decidual cast, as diagnosed by ultrasound, the obstetrician or gynecologist can consider suction curettage. Endometrial ablation, uterine artery embolization, and hysterectomy are invasive measures that can cause infertility and shouldn't be considered in adolescent population unless absolutely necessary, such as in life-threatening situations. Surgical options that spare fertility include intrauterine balloon tamponade and suction evacuation or suction curettage, either manual or with machine, and I will discuss both of them after a while. Intrauterine balloon placement is an effective, low-cost, accessible modality that doesn't require special training for insertion and can help avoid further invasive procedure. Usually, we using a balloon or Foley's catheter should be placed with a 30 cc balloon. The amount of saline needed to fear resistance within uterine cavity can be as little as 10 cc. Can be kept in place for 12 up to 24 hours, followed by gradual deflation of the balloon by removing 5 mm of the saline and evaluate if the bleeding controlled or no. In spite it is simple, effective maneuver, but of course carry its own substantial risk. Looks like risk of infection while the balloon is in, so antibiotic can be considered. Also, other risks of procedures include uterine perforation and damage to the endometrial lining. Most of the studies about use intrauterine balloon was carried on postpartum hemorrhage. There are no dedicated studies specifically analyzing the use of the intrauterine balloon in non-pregnant reproductive age adolescent and women with abnormal uterine bleeding. The second non-medical management of acute heavy menstrual bleeding is uterine evacuation. Sharp curettage can result in additional blood loss for the patient with a bleeding disorder and should be avoided in this population. So, no sharp curettage. Suction evacuation or suction curettage, either manually or machine, may be appropriate. Concomitant hysteroscopy may be of value to see if there is any anatomical cause for the bleeding. Concomitant placement of Mirena coil, levonorgestrel intrauterine device should be considered. Patient should be counseled about the higher risk of expulsion of the coil in this situation. The role of blood transfusion in case of acute management of adolescent with heavy menstrual bleeding and the primary bleeding disorder. Because the majority of adolescents with a bleeding disorder who present with heavy menstrual bleeding are otherwise healthy, often it is possible to avoid blood transfusion. Exceptions include hemodynamically unstable patients or those with severe symptoms of anemia as tachypnea, tachycardia, lethargy, syncopes. In general, adolescents respond to hormonal management and iron therapy quickly and tolerate anemia better than do adult patients. Theoretically, avoiding exposure to red blood cells antigen may reduce the risk of hemolytic disease of the newborn in any further pregnancy. Restrictive red blood cells transfusion practices and transfusion only for hemoglobin of 7 grams per deciliter or less to limit complications of allogenic transfusion. Again, as we mentioned before, management will be acute management and long-term management. I already discussed the acute management in the form of medical management and non-medical, and I discussed the medical in the form of hormonal medical therapy and non-hormonal medical therapy and the role of blood transfusion. Also, I discussed the non-medical management. I discussed the intrauterine balloon and uterine evacuation. Now, I will discuss the second part of management, long-term management. So, the patient now get controlled. What is the long-term management? It will include systemic hormonal management or use intrauterine device and the role of non-hormonal management for anemia. The long-term management, systemic hormonal management, intrauterine device, non-hormonal treatment of anemia. Adolescent girls with bleeding disorder may require a combination of hormonal and non-hormonal therapy to control heavy menstrual bleeding. A combined oral contraceptive tablets, the transdermal contraceptive patch, the vaginal contraceptive ring, and levonorgestrel all have been shown to reduce menstrual blood loss. Continuous or extended cycle use of hormonal contraception, either with pills or patches or ring, should be considered to reduce heavy withdrawal bleeding in adolescents with bleeding disorder. When selecting a combined oral contraceptive pills, monophasic pills that contain 30 to 50 micrograms of sentinel estradiol with a second generation progesterone should be chosen as first-line therapy because they are more likely to stabilize the endometrium than the lower dose formulation. If there is breakthrough bleeding, doubling the dose of the combined oral contraceptive until the bleeding stops may be preferable to allowing a withdrawal bleeding in this population. Some patients who experience breakthrough bleeding while taking 30 to 50 microgram sentinel estradiol containing combined oral contraceptive pills may have decreased bleeding with continuous use of 50 microgram sentinel estradiol containing oral contraceptive tablet. If estrogen is contraindicated, progesterone therapy is another option for adolescents and women who cannot tolerate estrogen containing therapy or in whom estrogen is contraindicated. Norethindrone or norethindrone is available as progesterone-only contraceptive pill, 0.35 mg daily, 0.35 mg daily. Its short half-life can lead to breakthrough bleeding and decreased contraceptive efficacy in adolescents. Norethindrone in 5 mg tablet is not indicated for contraceptive use, but can be titrated in doses of 5 to 15 mg daily for menstrual suppression. A small proportion of norepinephrine is metabolized to ethinyl estradiol, approximately equivalent to 4 microgram of ethinyl estradiol per 5 mg of norepinephrine. It is still classified as progesterone in the term of thrombotic risk. Breakthrough bleeding may occur. Subcutaneous formulation of medroxyprogesterone acetate are available for girls and adolescents in whom intramuscular injection is contraindicated because of increased risk of intramuscular hematoma. Although highly effective for contraception, the long-term management, systemic hormonal management, intrauterine device, non-hormonal treatment of anemia. I will discuss now the Mirena coil 52 mg levonorgestrel intrauterine device. Although research is limited, the levonorgestrel intrauterine device, which contain 52 mg levonorgestrel, appear to be an effective therapeutic option for adolescents with bleeding disorder. Co-management with hematologist is recommended to optimize peri-procedural hemostasis and decrease the potential risk of bleeding. A patient's cognitive status and the ability to tolerate necessary speculum placement should be considered when choosing the optimal placement setting, if it is outpatient or inpatient in the theater under anesthesia. All of this must be considered in multidisciplinary team involving the patient herself. The long-term management, systemic hormonal management, intrauterine device, non-hormonal treatment of anemia. The World Health Organization defines anemia in females 12 years and older as a hemoglobin threshold of 12 grams per deciliter. Iron deficiency generally is identified by serum ferritin concentration below 15 microgram per liter. First-line therapy for iron deficiency anemia include oral iron supplementation along with dietary counseling to increase the iron intake. CDC recommended that adolescent girls and women who have anemia receive an oral dose of 60 to 120 mg per day of iron. There is emerging data that once a day to every other day dose scheduling is more efficient than multiple doses because increased level of released hepcidin can decrease iron absorption. Three to 6 months course of iron supplementation is sufficient. A ferritin level should be obtained to confirm the complete resolution of iron deficiency. I finished the discussion of long-term management. I discussed the systemic hormonal management, the intrauterine device, the non-hormonal treatment for anemia. It is important to mention that in spite implanon is highly effective as contraceptive, but in adolescents with heavy menstrual bleeding due to bleeding disorder, the risk of breakthrough bleeding is high, so it is not the first line to be used by this population. Copper intrauterine device increase the menstrual blood loss, so it is not recommended for them. The use of aspirin and the non-steroidal anti-inflammatory drug is not allowed unless hematology consultant advice for this. Otherwise, it is relatively contraindicated. Hemorrhagic ovarian cysts. Increased incidence of hemorrhagic ovarian cysts has been reported in women with bleeding disorders. The cysts occurs as a result of excessive bleeding into the corpus luteum at the time of ovulation, and the rupture of this cyst may result in hemoptyemia. Systemic hormones potentially are an option for patients with recurrent hemorrhagic cysts and can be used in combination with levonorgestrel intrauterine device Mirena. Preparing the prepubertal girl with a bleeding disorder and her family for menarche is very important. Adolescents with non-bleeding disorders should be counseled before menarche and have a plan in place for the possibility of heavy menstrual bleeding with menarche. The patient and her family should develop a plan in conjunction with the patient gynecologist and hematologist. If reproductive concern is present before age of 13, an earlier visit to the gynecologist or other gynecological care provider may be needed. In adolescents with irregular menstrual cycle, the value and optimal timing of assessment and diagnosis of polycystic ovarian disease should be discussed with the patient, taking into account diagnostic challenges at this life stage and psychosocial and cultural factors. In fact, polycystic ovary disease as a reason of abnormal uterine bleeding in adolescent is very challenging topic, and ASHRI guideline about polycystic ovary disease referred for polycystic in adolescent, and detailed discussion about this aspect need separate lectures. We are planning to prepare it. Remember, multidisciplinary team for adolescent with heavy menstrual bleeding and primary bleeding disorder is very essential, can be considered as life-saving. Multidisciplinary clinics, including social workers, hematology, gynecology, working together with the patient and her family to guide her for best quality of life. This diagram shows the platelet adhesion mechanism. Platelet aggregation mechanism, platelet activation mechanism. Finally, I would refer you kindly to the reference Screening and Management of Bleeding Disorder in Adolescents with Heavy Menstrual Bleeding, American College of Gynecology Committee Opinions, for free download online. I am more than happy to receive your feedback, either negative feedback or positive feedback about the lecture. The lecture is available in my channel. You can subscribe. You can scan the code available in front of your kind care by your mobile, and directly you will be directed to my channel. Again, your feedback is very essential and very important to me. Thank you in advance. Finally, I would like to thank my daughter Lara, my wife, as they helped me to prepare these lectures, Actually, all the designs of the lecture was done by Lara and my wife. Thanks for them and for effort and therefore time. For who is speaking Arabic, I will say أرجو إن وجدتم في هذه المحاضرة فائدة أن تتذكروا أبي وأمي رحمة الله عليهما بدعوة صالحة. اللهم إن كان في هذا العمل خيرا فإني أهب صوابه إلى أبي وأمي، وإن كان غير ذلك فتقصير من نفسي وأستغفرك وأتوب إليك.